We're going to move on to my talk about what's next. And we're going to not only talk about thrombectomy devices, we're also going to talk about different things that we can use to manage chronic occlusions. If you can bring my slides up real quick. There we go. So these are my disclosures. So, we've seen a flurry of innovation and activity in deep venous disease in the last 5 to 10 years. We now have several purpose-built stents for venous anatomy, venous-specific thrombectomy devices that were not studied in randomized controlled trials, as the gentlemen up here have already told you. And we have lots of emerging data. But there are clear needs. We need treatment options for iliocaval chronic obstructive disease, which I'll talk about a little bit later today. A way to deal with obstructed stents, and not just meaning that it makes it easier to cross. Certainly that's a big part of it. But also, once you do cross, maybe not having to just put in another stent, because eventually you have the onion skin effect of a stent and a stent and a stent. I'm not ready to give up lytics, and I think we need a next-generation pharmacomechanical thrombectomy device that maybe can, as these gentlemen said, make on-table thrombectomy possible. And, we heard about the angiojet, but maybe iterate on that concept. And then targeting inflammation, because right now we have no way to specifically target inflammation as a process in venous obstructive disease. Occluded stents are a problem, and it's not a new concept. Mahmoud Razavi published this in 2015 in a meta-analysis of 37 studies, 80% primary patency in post-thrombotics at 1 year, 5-year projected primary patency of 60%. Young patients, this is not acceptable, right? This is, if 1 in 5 are occluded at 1 year, and then it's only 60% are open at 5 years, that's not good. And unfortunately, that's proving to be the case in IDE studies. Wire stent occlusion is difficult to treat. Well, the dense material occluding the stent, standard wire and catheter techniques often are not enough to get across, and then trying to remain within that stent lumen. Unlike on the arterial side, where the anatomy is relatively straight, when you're in the iliac vein, you are making numerous turns on your way up, and it's very easy to go out even with needles, RF wires, whatever you might use, and there's real danger there. And then that collagenous material that's inside is tenacious and really impedes luminal restoration. I mentioned what the IDE trials are showing in the Virtus data. At 3 years, they did show 60% in post-thrombotics. That's not good. These are young patients, malfunctioning prosthetic for the next 20 to 40 years, 30 years, whatever it may be. It's really not good at all. Vernacular and Abre not all that far off, and their 3-year data is actually under peer review right now. So what now? Stent occlusions in post-thrombotics are not becoming less common. We need tools to simply simplify that safe crossing of stent occlusions. We need technology to debulk stents, and more stents are probably not the answer unless it means stenting new anatomy that maybe was missed, an inflow lesion, et cetera. Improvement in stent design maybe to make them more resistant if that's a coating, and certainly there's work being there. But this is one device that's about to enter clinical trial. This is the Traversa device for venous recanalization. The idea being that it has a unique anchoring mechanism with that balloon to keep you locked within the stent, and then you put out a needle. And again, you have to be very careful with this multi-oblique imaging, and then work your way through an occluded stent or a native occlusion. I find that this is really has the potential to change how we deal with occluded stents and work your way through that. Here's a short video that shows how this works. I'll just let it play right here. You can basically steer. There's a needle. You can flex it one way or the other, and then you can turn it to change your orientation that way. And it's a standard 35 wire that goes through it. And this is kind of the idea. Minaj Kaja is the national principal investigator for this trial from the University of Michigan. And so we're looking to hopefully start this next year early and show that this can improve the safety profile of crossing and the ease of crossing. So I mentioned there's a study for regulatory clearance. Then there's going to be a post-market study to hopefully bring some reimbursement codes to treatment of chronic venous obstruction, because right now all you get is a stent code, which clearly belies the amount of work that goes into this. So that work will be forthcoming. So you've crossed. Now what? Stent in a stent, as I mentioned, is not the long-term viable option. Clear need to debulk a debulking device to restore the lumen after the problem is addressed. And of course, Inari has come out with their device. It's a relative to 16 French, I believe, right, in the pop, which is large, right? I mean, these patients have damage inflow. I worry that that's an issue, but that's my speculation alone, really, at this point. And then you have to put a protrusive sheath up because it does send up the liberated material here. But early returns from this is that it has potential and has worked well in some people's hands. This is another system that's under development right now by Intervene. It's called the Cronus system. Disclosure, I'm involved with this. This has a variable diameter helical blade. You can see on the bottom end here that you can basically change the amount of the blade, the diameter of the blade that comes out. They're working on whether it needs to be cutting or whether it needs to be blunt. And so far, they've had quite a bit of success in animals that are underway right now. There is an ipsilateral collection basket. In the early goings, they're going to also put in a contralateral collection basket for the early safety stuff. But they've been able to remove, basically chopped up squid, which is very difficult to remove inside of stents, and it's worked well. The idea, hopefully, is to have design freeze and validation in the final quarter of this year and proceed to first in human in Q1 of 2024, and then follow with the 510K. And really, they're focusing on ISR, but maybe hopefully expand into specifically removing that collagenous material that may impede inflow in certain vessels, specifically the profunda, that being the dominant vessel that, at least in my view, that will maintain a post-thrombotic stent patency. We already talked about this a bit in the evolution of DVT treatment and who we treat. We know we treat iliofemoral DVT patients with at least moderate to severe symptoms and a VOLT of 10 or greater, not routinely in femoral popliteal DVT, but again, we're trying to do single session treatment, maybe use less lytic. I know we've talked a lot about mechanical only devices, but remember, we have prospective data that shows that lytics work, and in 700 patients, no one died. No one got an intracranial bleed, and that's with a lot of lytics. So can we ratchet down the lytic and apply mechanical principles to treat these patients? And we know that there are a lot of devices. We heard about the AngioJet. The bottom right is the Jedi device by Abbott. There's, of course, mechanical-only devices here that you see with the penumbra and the Wolf catheter. Inari's ClotTriever in the top left, Vitex's, or not Vitex, sorry, Surmodics, Pounce thrombectomy catheter in the lower right. And then, of course, people are using AlphaVac and FlowTriever for larger volume thrombus, larger vessel thrombus. There's a new device that's out that's under development right now. This is from Sonovascular that looks to combine pharmacomechanical properties with mechanical thrombectomy to have an on-table solution. And the idea being that you can literally use microdoses of lytic suspended in microbubbles, facilitated with stable cavitation from an ultrasound transducer at the end of the catheter that then increases the amount of surface area that lytic is exposed to, and then that lytic is gone. We all know that the half-life of lytic is very low, and in their early trials, they've done whole limbs with 2 milligrams of TPA. We would not hesitate to use that in a declot. And so finding the dose, that's the work that needs to be done here, but we've shown, at least in early goings, that you can use very low doses of lytics and clear out the thrombus. And then, of course, you have the mechanical element to do the cleanup at the end and have an on-table solution here so that we don't have to do the ICU and we have a quick and safe procedure and are using a technology and a strategy that has been supported in prospective randomized trials, so really an extension of that. And finally, inflammation. Inflammation, we know that inflammation is a center portion of the conversion of acute DVT into post-thrombotic syndrome. The University of Michigan group is doing a ton of work here on interleukins, all sorts of things that are at play right here. But is there something that we can do from a procedural standpoint as we refine our understanding of how inflammation plays a role in the development of the post-thrombotic syndrome to maybe mitigate some of that collagenous transformation that we've been talking about? And we talked a little bit about this already, but if there are devices that are now available that can use needles to go into the interstitial space, very small needles, and inject high-dose dexamethasone into the periphery to maybe mitigate the effects of inflammation on the vessel itself. And there are two trials that are currently underway. This was originally developed for peripheral arterial application, and now with the larger size here, with the leapfrog into the venous sizes, and from 6 to 16 millimeters, and you give dilute contrast to get that kind of picture that you see in the top right. What you do, you open the lumen first, you treat the vein, you stent as needed, and when you're treating the vein, this bullfrog opposes you to one side. You inject your dexamethasone along the periphery. It's not a pretty picture, so to speak, that contrast grows away, but you're really looking to inject it along the periphery of the vein right here, and then potentially avoid some of the issues associated with post-thrombotic syndrome. Now, there are two trials. There is one trial that's going to be the early cohort just finished enrolling in acute femoral popliteal disease. There's one that is looking at the more chronic disease that's currently enrolling right now. So with that, I'll turn it over to Dr. Goldfinger for medical management.